Okay, so good evening, everybody. The content of this presentation is proprietary and confidential information of the Florida Firefighter Safety and Health Collaborative. It is not intended to be distributed by any party without written consent of our collaborative. Attendees should note that the educational component of this session is being recorded and will be published on the Florida Firefighter Safety and Health Collaborative website and YouTube page. To maintain complete confidentiality, an announcement will be made before the recording begins, and only the presenter will be identified during the recording. Therefore, to ensure anonymity, all attendees are asked to mute their microphones until an announcement is made that the recording is complete. Presentations are intended for the educational purpose and do not replace independent professional judgment. The ideas expressed in this presentation are the professional opinion of the presenter and do not necessarily represent those of the Florida Firefighter Safety and Health Collaborative or its constituents. Before acting on any of the information presented, attendees should consider the appropriateness of the information as it pertains to their individual situation and seek independent professional advice should any concerns arise. If you or anyone you know are in what is believed or perceived to be a situation that is or may become harmful, please reach out to the National Domestic Violence Hotline via phone at 1-800-799-SAFE, 1-800-799-7233, or through their website, thehotline.org, or dial 911 in the event of an emergency. With that, the recording has begun, and we are very grateful to be working with FHE this evening and hosting our four panelists. We will be hosting Dr. Nelson this evening. He's the Director of Clinical Services at FHE Health in Deerfield Beach. Dr. Nelson is trained in the integration of psychology in medical practices and is a specialist in cognitive behavioral therapy. Dr. Nelson has been a licensed professional for over 20 years, working in acute, subacute, and outpatient settings. Dr. Nelson is a frequent contributor to publications and has an extensive experience presenting to organizations at different conferences on subjects of mental health, substance abuse, and integrated behavioral health. Dr. Nelson has served as a therapist, supervisor, professor, consultant, writer, speaker, and administrator in a variety of settings and with diverse populations. Our second speaker will be Brian Mangan. He is a board certified in police and public safety psychology and is the president of Law Enforcement Psychological and Counseling Associates in Medley, Florida. Dr. Mangan consults with over 60 law enforcement and public safety agencies in Florida, in addition to some federal and international agencies, primarily conducting pre-employment psychological screenings, psychological fitness for duty evaluations, critical incident stress debriefings, and therapy services. He currently serves on the executive board of Police Psychological Services section of the International Association of Chiefs of Police and the board of directors with the American Board of Police and Public Safety Psychology. Our third speaker will be Father Ron Perkins. He has been a public safety chaplain since 2009 as a member of the Federation of Fire Chaplains and the International Conference of Police Chaplains. He serves as the senior chaplain for the Fort Lauderdale Police Department, as well as Fort Lauderdale Fire Rescue and Coral Springs Parkland Fire Departments. He has over 3,500 hours in the field with fire rescue and law enforcement personnel, including active shooter incidents at the Fort Lauderdale Hollywood International Airport and the Marjorie Stoneman Douglas High School. In 2016, Father Perkins formed a nonprofit organization, Public Safety Chaplaincy, Inc., to provide consulting and management services, as well as direct chaplaincy to public service departments. After graduating from Mercy State Hospital School of Nursing, he served as a U.S. Navy Corps officer specializing in pre-hospital and hospital-based emergency medical services, including services as a medical evacuation coordinator for the evacuation of Saigon. And lastly, we welcome Eric. I'm not going to attempt your last name. You do you. And Eric is a firefighter with Cape Coral since 2004. He's a union president for Cape Coral Professional Firefighters Local 2424 IAFF from 2014 to 2020. He was the 11th District Vice President for the Florida Professional Firefighters since 2019. As District Vice President, he oversees Collier Lee Hendry, Highlands, and Glades counties. A member of the IFF disaster relief team since 2016, we are grateful that he is here this evening because of the very minimal effects of the hurricane last weekend, and he was not deployed. So with that, now full, which I give myself full credit for getting out with minor stumbles, we welcome first Dr. Nelson. Thank you for being here this evening.
Great, thanks, Michelle. It's great to be a part of this esteemed panel and to be meeting with everyone tonight. Again, I'm with FHE Health. We're in Deerfield Beach, have been for 20 years, and we have a specialty program working with first responders, military, corrections officers, firefighters, everyone across the board, and have really been touched by the challenges that are facing everyone right now. And just so we all are kind of on the same page, you know, this is not just one group of people. It is really everyone is facing the stresses and the difficulties that are going on right now. And when we talk about breaking the silence, it's very important that we're talking to everybody. And it's especially important for the family members of first responders because this is a very stressful time for everyone. And as we look at this time period, we're seeing a lot of disturbing trends across the country, not just the disease issues with COVID, but things like domestic violence, child abuse. We're seeing alcoholism and drug use really back to levels that we didn't think we'd ever get back to. People are facing suicides. We're facing the losses of so many different people in our life. And then we're also losing our sense of normalcy. And as we go through our life and this becomes kind of a more long-term issue for us, it's really taking a toll. And a lot of people hear about like COVID fatigue, all of these different things and the uncertainty that people are facing right now. So there's a lot of challenges and none of us are immune from mental health or substance abuse issues. I think tonight I'd just like to kind of focus on the idea that a big reason why people don't ask for help is because they don't know they need help. In the first responder communities, you're really taught to go through it, tough it out, get to that point where, you know, again, you can rely on yourself. There's a lot of stigma around asking for help for a lot of us. And it's really an issue, I think, that as family members, as professionals, coworkers, sometimes we don't really recognize when the warning signs are there. And so it's really important for us to get an idea of kind of what's going on. We talk about stress, and stress is really a normal human emotion. And sometimes stress can be good. It can kind of push you towards something. It's usually short term and then it ends. It's not a big deal in our life. We can also have what's called traumatic stress. And traumatic stress is really when a specific incident happens. And given that's the enormity of that particular event, we have a very heightened sense of stress. And it really looks like what we call post-traumatic stress disorder that I'm sure we're all somewhat familiar with. The idea with traumatic stress is that it may look a lot like PTSD, but it goes for a short period of time and then it gets better. And so you don't tend to see the long-term effects. With PTSD, what you see is you'll see the hypervigilance, you'll see people with the disturbed sleep, the startle response, and it will actually get worse over time. Add to this also just anxiety, uncertainty and not knowing what's happening, not being able to 100% protect yourself, really creates an anxiety level that if it becomes chronic, can really start to affect both your physical being and your psychological wellness. As we're seeing with a lot of the stuff that's going on right now, we don't have a lot of our normal healthy outlets that we would normally go to. So whether it's social distancing and you're not spending time with friends or family members, maybe we're missing out on our normal routines, maybe religious services, maybe support groups, maybe 12-step meetings, whatever it may be. And just the ability to interact with folks that we normally would, things have changed. And this becomes a real problem because people tend to shut down, and they're not going to be out there, and they're not going to be being seen by people. And a lot of times, some of the warning signs might actually get missed. And so a lot of times family members are the ones who are going to see somebody suffering. And it's important when we start to think about families and coworkers that a lot of times you're going to see the changes in people before they're going to see them in themselves. And so it's often important to really begin a process of being able to talk about what's going on. And I always encourage people who have concerns for their family members or coworkers that they start with the idea of really expressing that concern. And so a big part of it is saying to them, you know, again, I'm concerned about using my I statements and really giving yourself an opportunity to express your concern for them. Then a big part of this is listening. You know, people can open up, and if they feel like you care, they're going to start sharing the struggles, the problems that are going on. A lot of times it's not comfortable for people to be seen in a way where they feel like, oh, I need help, or I've got a problem. The idea about this is we want to normalize that human beings have feelings, we're facing stressors. You know, this is a time period where a lot of my patients that have anxiety, they said, you know, they actually have been getting through this pretty well because for the first time in their life, everyone has anxiety and they don't feel ashamed to share it. But when you're opening up and kind of sharing that you're concerned about somebody in your life, it's really important that you be a better listener than trying to tell them what to do. It's important for you to do it calmly, to be able to talk to them about what you're seeing and how you're concerned. And if you can create that dialogue, a lot of times people are going to start to open up about what's going on for them. And that's one of the best things we can do. It's also important, too, is that we can't always, whoever we are, be caregivers. Sometimes we need to be able to get care, too. And opening that door and being okay with that is sometimes difficult to take. But again, we want to normalize that all of these different situations we're facing, unfortunately, they happen. And we get through them. And we want to give people that sense of hope, and we want to give them that sense of support. And so hopefully we'll have a good dialogue tonight about how we can do that. And thank you for letting me be here.
Thank you so much, Dr. Nelson. You brought up some really great points. Next, we will be moving on to Brian.
Good evening, everybody. Thanks for having me be a part of this. I'm excited to be a part of the discussion and really bring a lot of continuity to what Dr. Nelson was discussing and opening up with. I've made some points on my screen that I'll refer to throughout the discussion, but I didn't want to formalize this with PowerPoint presentation. I think I wanted to have a more informal, open discussion about my personal experiences in this line of work for the past 15 years, working with both police and fire rescue. And from both the beginning and the onset of my services, which would be for pre-employment screening and selection, all the way to investment and excellence courses, which is for retirement of public safety personnel. So first and foremost, I think to really bring a light to services that we provide, the pre-employment screening is really important, and it's a great way for agencies to select really good personnel who are going to be coming into this line of work, which is a very specific, difficult, high-stakes line of work. And fire rescue historically hasn't done the pre-employment selection as much as pre-employment screening, rather, as much as the police agencies have. So the disclaimer that I have in this is that most of the pre-employment screening we do is with police agencies. slowly but surely over the course of the last 10 years, we've really opened up to a lot of fire rescue agencies being a part of this. And sometimes this starts with one major agency taking a role in, or even an administration or a command staff, a chief taking a role and believing it's very important for the well-being of the agency. That's the important part. Knowing that it's such a stressful career, it's to establish an onset of well-being for the agency. And so recently, Miami-Dade Fire Rescue has started the screening process, and a lot of agencies, I think, are following suit and will continue to follow suit. So when the screening occurs, I'm not going to get too much into that. That's not really the purpose of this discussion, but it really is one of the secondary benefits of the screening is to allow a candidate interested in this line of work to meet with a psychologist, maybe for the first time, and a psychologist who's trained in understanding police and public safety and fire rescue and the services they provide. And this gives us an opportunity, particularly for those who make it through the process and become firefighters, paramedics, EMTs. It gives us an opportunity to plant seeds, to really get them to feel comfortable sitting across from a psychologist, someone that they never would have maybe thought of sitting down across from, in a very benign manner. You know, it's not therapy, it's screening. And so their guard is a little bit lower. Obviously, they want to get hired, but they're not coming to us because they're presenting with any issues or concerns at that time. So it allows them to have a little bit more of a free approach to discuss their life with us and feel comfortable with us. In the discussion with them during the screenings, we often talk to them about their support system. We want them to identify their support system. We want them to consider their support system and to never forget their support system and how important this is to them throughout their career. So we will discuss some scenarios with them, maybe some directly work-related scenarios, and then we'll find out how much they can reach out to and believe to benefit from the support that they have, and we encourage them to consider that. That's the planting seeds. But a great part of what we do after that is we provide services that we call sort of maintenance services. These are services that are voluntary counseling, EAP services, the Employee Assistance Program services. We provide critical incident stress debriefings, group debriefings, and individual debriefings. And we also provide wellness checks. Now, all of these services are more of a maintenance approach to guide a first responder through the course of his or her career. The differences that I've experienced, and these are anecdotal experiences, in public safety first responders are vast. Firefighters and working with fire agencies, fire rescue personnel, going to the stations is vastly different than working with police agencies, correctional agencies, dispatchers. And so focusing on fire rescue, I think some of the major unique differences that we have with fire rescue and fire rescue personnel is that it's a much a family approach. It's a family feel for the shift work that's involved, for the closeness that you all have to each other. It's a very close-knit family, which is fantastic because healthy families provide each other great support. However, unhealthy families can be torn apart, and that can be a problem because that can spread very quickly. So for all of you in fire rescue, you know, the agency can be strong, but every substation or every firehouse can be vastly different from each other and have their own personality, their own pulse. And so it's really important for providers, for people involved with the services with fire agencies and command staff and administration to be very aware of the differences with the firehouses and the different family units that are within those facilities. There's one commonality, though, with public safety, and the one commonality is the reluctance. I think Dr. Nelson was hitting on this as well. The reluctance for service. And there's many reasons why, as was mentioned earlier, there's many reasons why, and I just want to kind of throw out a few of what I've experienced. A reluctance for EAP or a reluctance to reach out to a therapist, a psychologist, can be due to pride. It's just sheer pride of feeling as though you're strong enough to manage it and you'll get through it. Tomorrow's a better day. Sometimes that is facilitated within the locker room mentality sometimes of It's like a sports team. We're going to take care of each other. We're going to boost each other up. And there's a lot of pride in that. And that's okay. That does service some, it does provide good service at some times, but it's not always going to work. There's also a clear concern for confidentiality. That's a big thing for first responders, for firefighters, for police. Confidentiality, the concern that if I go talk to the shrink, it's going to ruin my career. The shrink talks to the chief, it's over. And that's a real concern. And one of the main things that I know I do, as well as I'm sure Dr. Nelson and other professionals in this field do, is to establish that understanding and that strength and belief and trust that confidentiality is first and foremost on our mind. We lose our license if we violate confidentiality. Of course, there are limits to that in terms of direct threat, harm to self or others, or current child abuse, elder abuse, things like that we have to report. But beyond that, the specifics in confidential therapy are confidential, and that's something that we have to make sure is understood from the onset to make it work, or else it's not going to work. There's also self-preservation. Firefighters, first responders, the self-preservation is strong. And there's a sense of, if I communicate these true emotions that I feel right now, I'm going to make them real. It's going to be out there. And I can't do that, because if I do that, then I'm going to have to face them. So if I repress them, if I don't make them real, I don't have to deal with it. And so that's a coping mechanism. It's a maladaptive coping mechanism, and it usually will, the experience of it will usually manifest in many other ways, such as irritability, anger, gambling, drinking, a lot of other problems. And so we have to get to the root of that. But there's a self-preservation that first responders tend to reach to quickly to manage their own emotions. But on the flip side of that, there's also a sense of protecting others. There's a strong sense for first responders to protect people. They don't want to make people's lives worse. They want to make people's lives better. That's why they're out there every day protecting and serving people. With that being said, they don't want to necessarily make other people's lives miserable by sharing their own dark feelings. And so they feel as though, I'm going to lessen, even with psychologists, I'll lighten up what I really feel, because I don't want to harm you in any way and hurt you in any way, or make you sad or miserable in any way. So we have to really be prepared to allow them to open up, and then make sure that they don't pull back quick if they feel as though we're being negatively affected by those emotions. There's also the misconception, as Dr. Nelson pointed out, about misconception that emotion is a weakness. And that's something that it's a stigma we just have to break. And also the last one I wanted to touch on is that a misconception that therapy is long and draining. There's this, historical, antiquated contextual belief that therapy is like you see in the movies, and it's not the case whatsoever. It's first responder therapy, in my experience, is like surgery with a scalpel. It's quick, you get in, you get out, and you try hard to be solution focused, and to really find ways that this person can open up and then manage and then move forward. And the time is obviously also limited. The shift work is tough. When you're not on shift, you want to be home with your family, which we support entirely. That's a great support and help. But it's very, probably I would say maybe 6 sessions is probably the average amount of sessions to come in and just be solution focused. And once we help educate agencies and families about the services we provide, and help explain the scope of those services and the framework of those services, dispel some of those myths, I think that they're more open to using them. And now, one of the unfortunate, one of the fortunate outcomes of COVID has been virtual meetings, virtual trainings, and we're doing therapy mainly now. 85% of it is through a DoxyMe, which is a very secure, HIPAA compliant portal that allows us to see our clients in the station, in their house, in their car, not driving, of course, but usually in their parking lot. And it's the availability and flexibility has allowed the therapy hours to go up. It gives us a further reach and is very beneficial to all of this. When all of this is put together, though, the most important part is that the provider that agency should involve should be culturally competent. And that is someone who is familiar with the ins and outs of the specific line of work, fire rescue, firehouse, shift work, responding to critical incidents. That's so important. There's an understanding within the cultural competence of training. Training is paramount when it comes to first responders. Training is necessary, but it's also something that normalizes their experiences and creates this sense of dehumanization. And that's a coping mechanism. If I pull myself away and I forget this is a person and more of a problem that I have to solve, I'll manage the situation. Because if I realize that this is an actual person, I'm going to be emotionally affected. So I got to pull that aside, dehumanize the situation, and manage it the way I've been trained. You do that enough over time through scenario-based training and actual experiences, you can create a wall. And what we have to do when we're dealing with the debriefings, the wellness checks, with the therapy with first responders, and for families to help families understand, is we have to help them understand that an emotional reaction to your job, to a situation on the job, is a very normal reaction to a very abnormal event, versus what often is the outcome of so much training. The outcome is typically what we experience on a regular basis is totally normal. And if you have an emotional reaction to this, that's an abnormal event. And so we have to switch that. It's that mental switch of understanding. You're having a very normal reaction to an abnormal event. What you experienced, 99.9% of people don't experience on a regular basis. They don't go to their job and deal with what you do. So you're having a very normal reaction. You help them normalize their emotion, and then they're more open to talk about it. And we want them to understand we use a lot of visualization in a way, not in the therapeutic sense, but more of like analogies and help them metaphorically understand things. And it's a sense of helping families and help officers understand, the first responders, that their incidents build up over time. It's like a tower of Jenga. You know, when you pull blocks out of Jenga, you eventually leave holes. And eventually, when you pull that one piece out, the tower will fall. But you'll look at all the pieces and say, well, that piece I just pulled out was the same exact piece as the 5, 10, 15 pieces before it. Of course, one piece wasn't worse than the other. But over time, the more you pull pieces and the more you don't realize that there's no scaffolding in effect, the tower will fall. So family support services through everybody on this call right now, being aware of the wellness checks, the EAP program, the different programs that we can provide, which I'll get into in 1 second, and then I'll be done, will provide the scaffolding for first responders to hold themselves together, because we're not going to stop pulling pieces out. You're going to deal with that. And one size does not fit all. Not everybody is keen on individual therapy. Not everybody's keen on group debriefings. And I love going into fire rescue, firehouses, because they're really great with group debriefings. Way better than police in my experience. So that's a benefit, but not everybody is going to benefit fully from group debriefings. Some people benefit tremendously from individual debriefings. So it's something that we have to look at: individual debriefings, group debriefings, EAP, wellness checks, and all of those types of things. Also, rookie training, getting new first responders and making sure we're training them from the get-go in stress management, coping mechanisms, understanding the importance of the resources and the support system they have with family and with people like us. Also, line supervision training to help them pick up on signs and symptoms of mental health and of concerns, that they can reach out to us for guidance, or they can intervene and assist at the time. And the most important part, I think, of what we need to do and develop and facilitate, which is a major part of the call tonight, is family training. Michelle was mentioning something in the beginning about what can we do more. I think we need to have, I think every agency should have a family liaison, an assigned family liaison within the agency that facilitates communications, has a like a listserv with family members attached, a chat with family members where we can share resources, share our brochures, share trainings, and be available to family members to help answer questions and to help them walk through and navigate the course of the career of being a first responder family member, because first responders are trained in all this stuff. Family members who don't have any first responder experience aren't, and we need to be available to them to assist them through. Some of the resources that I'll put in the chat, some of you might be already familiar with these resources, but I think they're fantastic. The West Coast Post-Trauma Retreat, and that's the First Responder Support Network. And I'll put this in the chat so you can go to the website. These are some of my colleagues, my esteemed colleagues. They're amazing people. Mark Kamina, Joel Fay, Alan Kirchner. They are people that they have started this retreat. They have law enforcement, public safety, first responder experience. And the website has resources not only for first responders, but also for families of first responders. And so I really encourage you to look at this website to gain more resources. And also, Ellen Kirschman has published a great book, which I'm sure you're all familiar with, which is I Love a Firefighter, What the Family Needs to Know. I would recommend you all read that. And then the last thing I think is an awesome way to really tap into the resources that are available to us now is to have podcasts. Listen to a podcast in the car when you're with your family. You know, obviously, audience consideration within that is it might not be some things that are good for little kids to hear, but if you're in the car with your family members and you can listen to a podcast, there's a podcast called The Firefighter Deconstructed, which is an awesome podcast that touches on a lot of these topics. And I think it's very important for you to utilize all the resources you have to best manage the course of this career with yourself and the family. And I'll put some of that in the listserv, in the chat room, and I'm always available for any discussion, questions, and everything. Thank you very much.
Thank you so much, Brian, for all that wonderful information, and we're looking forward to seeing those resources and spending some time with you after. Now we're going to invite Chaplain Perkins to speak, and I'm very excited to hear from you, Chaplain.
Thank you, Michelle. I appreciate it, and thank you to the doctors. It's always hard to follow doctors. First of all, disclaimer, I am not a therapist. I'm not a bad listener, but I'm definitely not a therapist. So I'm going to kind of talk about this whole culture of silence and what we do to help first responders from maybe a little bit different perspective. First, some good news. I've been doing this now for about 12 years. And I can say that I have seen a tremendous change in the command structures of the fire and rescue agencies and law enforcement agencies that I serve. One that is much more open and inclusive when it comes to behavioral health issues. As a matter of fact, the collaborative and Falls Parkland Fire Department has really developed a model that is being a 57-page model, I might add, that is being implemented not only throughout Florida, but is being looked at from a national and international perspective. And that is basically the Behavioral Health Access Program, which includes 4 critical elements. The first and the real driver of it is peer support. It's you guys and gals in the field, whether it be fire rescue or law enforcement officers that are working, that have received specialized training and education in how to interact with your peers, the rules and regulations relative to confidentiality and disclosure and those kinds of things. And as importantly is listening skills and the ability to determine at what point your peer needs more professional care or access to the other steps within the Behavioral Health Access Program. Obviously, chaplains are important to that. And just one plug from the chaplaincy perspective, we're not here to represent a faith or a specific religion. A good law enforcement or fire chaplain or chaplain, period, regardless of the environment that they work in, should be a supportive person and one that accepts people of all belief structures and none. And it's amazing to me every day that I go to a firehouse or do a ride along with a police agency, and what few times actually religion comes up is how very often someone professes to have no religion, no faith, and actually are agnostics and atheists. And by the end of our ride along conversation, they are asking questions in terms of, is this belief structure I have okay? I think it's okay. How do you feel about religion or a higher power is totally between you and your creator or inventor, however you want to look at that person or entity. So I think chaplains are important to this, but also a critical element, obviously, the two doctors that we've heard from, the clinicians, whether it be master's level or social workers or therapists or PhDs, psychiatrists, and so forth. There comes a time when people need that level of professional care. I probably refer on average 2 to 3 first responders a week to professional care. And I always refer to individuals, regardless of level, who have documented experience in additional education and training in first responder care. Because as Brian said, it's quite different in going into a therapy situation as a first responder, where you might have to spend your first session explaining what a Kelly day is and what shift work is and sleep deprivation and all the rest of the stuff. And then the other element, the fourth silo of this, if you will, has to do with critical incident stress management. Brian talked about debriefs. We made a good point pointing out the difference between a debrief how to implement CISM. Although I'm proud to be working with an agency here in Fort Lauderdale PD, there's a full-time, fully accredited police psychologist. And Rob has only been on board for about a year or so, and he's totally turned around the concept of CISM within PD. And we're actually now doing some CISM debriefs where we're having law enforcement officers and firefighters in the same room. And that again, is really moving things a lot further. I want to take just a minute and talk about the elements of family involvement. I think our doctors have done a good job of talking about stigma and the fear of loss and why we have this culture of silence or had it for a long time. But families, I think families and coworkers are critical elements in the support system. And this is coming up on a very important month. Next month, September, is Suicide Awareness Month. And as you all know, the incidence of suicide among first responders is much higher than the general public. So we want to take a moment and reflect on that, particularly next month, as we go about our station visits and talking with people about watching out for signs and signals that someone may be approaching consideration of that. And one of the things that I think is most critical is change of behavior. And that can be good or bad change of behavior. And the whole element of, again, your family, both your work family and your home family, are going to be able to pick up on those changes in behavior around, particularly a firehouse where someone has been typically social and now they're hanging out in their room as opposed to hanging around the kitchen, is a signal. And as is if someone is normally a reclusive guy and all of a sudden he's now gregarious and he's hanging around with the rest of the crew. The other issue that oftentimes comes up is a distancing of home and from their home and from their work life. And then obviously, I think Dr. Nelson did a good job of talking about self-destructive behavior, where oftentimes you see an increase in alcohol or drug use, or even something that we don't think about often is like all of a sudden they're not wearing their seatbelts or they're driving exceptionally fast. those kinds of things are things that you can pick up on just by watching the people you care about, whether they're your loved ones or people that you work with. One of the concepts that the collaborative is really coming out with is the concept that it's okay not to be okay. And I think that concept is really, particularly in the fire service, but I'm even seeing it now in more enlightened law enforcement agencies, the understanding that not everyone is okay all the time. And as Brian said, critical incident stress is a normal reaction to an abnormal event. Well, as in first responders, we consider a lot of what we see abnormal. And normally we respond in a normal situation, it's just for work and so forth. But there are those individual cases, and probably 60% of the CISM responses that I get involved with, 60 to 70% of pediatric deaths, where that's not your everyday occurrence, and kids and dogs should not die. And if you want to get a firefighter upset, it's over kids and animals in a fire or other situations. So I think it's important to do CISM debriefs, whether it be in a formal situation or a lot of times, particularly in law enforcement, we'll do it on a one-on-one scene or hanging around a cup of coffee or something. The other thing I wanted to talk about just briefly from a family perspective, and again, I'm talking now work family and home family, but it's knowing your resources, to know what your department has, whether it be an EAP program with referrals to clinicians that are appropriate and educated in first responder care, or whether it be the chaplaincy program or peer support or what have you. But when you have conversations with your loved ones, I think Dr. Nelson brought it up, is to be direct. The I statements, I'm noticing this about you, but to be direct and not beat around the bush about that, but at the same time be supportive of the individual. And the last thing I want to mention is remember to take care of yourself, whether it be a first responder, a family member of a first responder, or someone who's caring for first responders on a professional basis. We can't do a good job of taking care of the next firefighter, the next police officer, the next family member, unless we take care of ourselves. And that goes for all of us. Everybody that's on duty and everyone that takes care of people that are on duty. At this point, I will turn it back to and I'll be happy to answer any questions at the end.
Thank you, Chaplain Perkins. It's always nice to hear from you. Now we ask Eric. Eric, thank you so much for joining us. What you're going to teach us this evening.
I couldn't really hear you, Michelle. You kind of broke up there, but I think you were kind of segueing into myself. So first of all, I want to say thank you for having me, Michelle. I'm very honored to be a part of this panel. I will say I'm a little upset that you put me forth, because how am I supposed to follow these three individuals? It's not really fair, but I'll try my best. I think what I have is, in relation to this, is a unique perspective that I am a first responder, and I am on the front lines. Not only do I work with these individuals, but I was their union president for many years. So much like we do in the field when we run a medical call or a car accident or things like that, we get hands on the patients first, and then we take them to the hospital. This is much like that situation as well. So I get to see my brothers and sisters firsthand before these gentlemen do. And that's a big responsibility for us to be our own brother's keeper. I can tell you from firsthand experience, a good friend of mine who was on my crew confided in his crew and came to us with some issues and everything, and we felt that he was reaching out for help, and we made the appropriate phone calls. Well, I do have to tell you, this is one of my first experiences. I felt like we put him in an awkward position because he ended up being Baker acted based on some of the things he said. And in our opinion, and speaking to him afterwards, we felt like he was put in a worse position than when he reached out for help. So I think that there is certainly lack of information out there. And I just think it's the firefighters' inability and reluctance to deal with this. I think it's better than it has been. I started becoming a firefighter in 2003, 2004. And back then it was taboo to even talk about this. The old guard, no way, you just wouldn't do it. Jokes were made from the individuals that frowned upon it, but I certainly think, in my experience as president of Cape Coral, unfortunately, under my watch as president, I had a brother who took his own life, and it was very surprising. Since that time, I think we have done a good job of trying to combat that with the collaborative and some of the things we put in place, but I don't think we're there. I think we still lack, but I think as much as we're trying, we have to keep trying, but I think it's just a scary situation for firefighters to deal with. We are taught to be the alpha male and fix things, and I think Brian hit the nail on the head when he brought up the Jenga thing. You know, we run a call, we deal with these situations, we put in a compartment, we close it, and we move on to the next. Well, you know, these things pile up and pile up and pile up, and I'll be the first to tell you, I've sat around and thought about calls and stuff before, and I haven't had it as bad as some of the other people, so I can only imagine what they go through. When it comes to the family aspect, I know this because we have had where we brought with our health insurance trust, we brought people in to come, and Dustin, I believe, was the one that we brought in a couple times and tried to talk to our members and bring their family. We even had a family night where we said, listen, bring your spouses or whatever, so we could talk to them so they could look and see, you know, are you changing your routines at home? Are you acting differently and stuff like that? Where I think we're missing it is if we can't get buy-in from the firefighters, we're certainly not going to get buy-in from their families, because they're just not gonna open up to them, because I think we're just scared of it. Firefighters just don't want to not be invincible to a point. The ones that I've talked to. Now, I have had numerous ones reach out to me throughout the course of being president and now district vice president from all over. They just want to talk to somebody, and they don't want it to go any further. What scares me about that is I'm not going to say qualified, because I can understand, but I'm certainly not a doctor or a therapist or even a member of the clergy. I think you guys have more experience when it comes to that, but they ask us not to break that confidentiality. So unless, you know, they allow us to do that, sometimes we have to bite the bullet. Like I said, I was put in an awkward position where I felt like while I was doing the right thing for the member, I also felt like, oh God, this guy's going to get really upset with me because of what I just put him through. So my benefit here is I think I can answer any questions in relation to things that happen on the front line before it hits these individuals. So I can't really speak on anything more than that because you guys took all the wind out of my sails, but I welcome that. So if I can answer any questions aside from that, I welcome it.
Thank you so much. Can you hear me better now? Awesome. Okay, let's start taking some questions, and I'm gonna get my screen to share here. Does anyone have any questions that they'd like to ask? Reminding you that we are being recorded, and so if there are no questions that anyone wants recorded, I will end the recording. Okay. I actually have a question that was brought to my attention. Somebody mentioned to me their feeling of the fact that the confidentiality discussion sometimes often presents as almost an excuse for people because we've really come a lot of a great distance in creating confidentiality on departments. Do you feel like maybe that's a crutch that people use at this point? At the expense of being vulnerable? That's directed to any of you that want to answer.
Could you repeat that, Michelle, please? I'm sorry.
Sometimes it's suggested, my partner is a retired deputy chief, and you know, we've come a long way from creating more confidentiality when somebody
Would
wants
you
to
like
come
me to say?
forward. Yeah, sure.
Okay. So basically what I'm saying is that I feel like sometimes people will hide behind the idea of confidentiality at the expense of being vulnerable. They'll say, I don't want to, the risk of someone breaching confidentiality, but really what the main concern is, I don't want to be vulnerable in the process.
I think, in any situation, people have lots of good reasons why they don't get help. And they will rationalize their behavior, and a lot of people are afraid of the consequences. I think this is something that, Eric had mentioned in his situation. Sometimes when somebody's a threat or danger to themselves and about it, it's really often not fair for them to just come to you and say, well, you can't share this with anybody. Sometimes life and safety, as any first responder knows, comes first. But you're probably right. There are people who say that it's not safe to talk, that no one will understand them. I have first responders who have to go into group therapy, and they say, I can only talk to people who've been exactly where I am. No one else will understand me. And that's a very convenient excuse, but what it does is it prevents them from getting the help they need. So sometimes people are going to have excuses. The idea is that all you can do is what you can do, and we try to be supportive and helpful and often connect them with maybe a resource, but all we can do is what the person's willing to do.
One of the things in the state of Florida, there are different levels of confidentiality and privilege that are granted. And I think Dr. Nelson said earlier in terms of what a licensed mental health professional's level of confidentiality goes to. And if you've not been in a therapy situation before, and the very first intake interview, if you will, the therapists are very, very careful about drawing that line in the sand, if you will. Everything is confidential with these sessions. And that also confidentiality typically is confined to a one-on-one conversation, although group therapy may have some special parameters. And then peer support has recently been granted some level of confidentiality under statute, as has a CISM debriefs have been granted a level of confidentiality. Chaplains, according in the state of Florida, we're one of the few states that go to the extreme of excluding clergy from a mandated reporter status, which most of us in the clergy don't agree with, but it is what it is. How we handle that is if someone comes to us and is saying if they're going to take their life and hurt someone else, then we have to deal with it in a different manner than necessarily picking up the phone and calling the local authorities. Confidentiality and privilege is attached to a specific conversation in a specific parameter.
Michelle, Tracy had a question.
Yes.
He had said that to what extent do speakers discuss moral and soul injury in addition to occupationally induced trauma with their patients? And Tracy, that's a very insightful question. Moral injury is often when the person takes on the guilt or shame, feel like they weren't able to do something in a situation. And so when we're talking about silence, a lot of the situations they face, they actually turn it on themselves and say they weren't good enough, or someone else could have been able to save that person, or all of those different components. And it really adds a whole nother layer to the stress that people are facing. And so you do see this a lot, although very few people know what to call that. But you'll often find a level of guilt and shame that people have over a traumatic experience. And that can often be one of the things that really prevents them from talking about it.
I agree. A lot of the experience that we've had with moral injury has been in critical incident debriefings when an officer or a first responder will come in and express more concern regarding the moral injury than actually dealing with medical emergency medical emergency itself or the violent criminal act itself. More of what they saw beyond that, living conditions, the family, the way the family was, whatever it might be, that goes against their core values, their beliefs, their spirituality, whatever it might be. And so we have to be prepared to be very adaptable to the person coming in, the first responder coming in, to be prepared that their reason for coming in that day or how this critical incident debriefing could manifest throughout the course of our meeting could be wide-ranging and quite a variable from one individual to another. So it's definitely something that we need to be aware of. And just while I have the mic, just want to take one step back before we continue in this path. I was looking for the Florida state statute, and it does state that a first responder peer may not divulge information from or testify about a peer support communication in a civil, criminal, administrative, or disciplinary proceeding unless there are articulable facts or circumstances that would lead a reasonable, prudent person to fear for the safety of the peer, another person, or society, or a strong belief that a peer has committed a criminal act or intends to commit a criminal act. So that's specifically how it's stated.
Thank you so much for answering that. Moving backwards a little bit, because we jumped forward to that moral injury and soul injury. Someone asked, how can confidentiality be guaranteed legally if you're not a therapist, psychologist, or clergy? I see Dr. Nelson shaking his head. Can you answer that, Dr. Nelson?
It can't be. There's no possible way to have that. This is a thing we have often when the people are in a group setting, and we say it's literally you can't guarantee it. And so once something's out there, something's out there. And that's generally why I tell people is that there is a benefit in talking with a licensed person or someone who can really be able to maybe address the issue rather than talking around the firehouse to everybody about something you did. Now you can get peer support, which is hugely important. But if there's a real problem that's going on, then we really end up in a situation where somebody can quickly spiral into a bad situation. But you can't guarantee legal, the full confidentiality for someone who's not a professional or doesn't have a legal mandate for that.
If I may, absolutely not. Firehouses are notorious for gossip. And if something happens at the firehouse or around a table and there's a crew there, you can bet your bottom dollar that crew is going to the next shift and they know about it and it's going to spread like wildfire. That is definitely reality in the firehouse. You know, the big joke is sometimes we're worse than a bunch of sorority girls because we just gossip so much. So that is a real concern for why people don't reach out at the fire station. But, I'm sorry.
Go ahead.
One of the questions that comes up with peer support a lot is many of our peer support people are lieutenants and some captains and even had some battalion chiefs function in a peer support situation. And it potentially can put that individual officer / peer support person in a conflict situation. An example, a firefighter comes in and says, I want to talk about my alcohol problem. I've got a bottle of Jack in my locker and I've got to take a hit every couple of hours. And he's telling that to an officer who has a fiduciary responsibility not to let that person get out of the truck impaired. And so where does that line come in? How do you deal with that from a peer support standpoint?
I agree with everything that's been said with the panelists, and that's why it's so extremely important to have a licensed mental health consultant as a part of the oversight for the peer support team, somebody that can be reached out to immediately under circumstances like that.
There are some really interesting discussions going on in our chat. I am looking to see if we covered all of the questions. It looks like we covered all of the questions in our chat box. Does anyone else have any other questions before we stop the recording? Okay, well, with that, we thank everybody who took the time to listen and join us this evening. We are going to go offline, offline now and have a confidential discussion. Thank you, everybody. Have a good evening.